Okay. All right, I will be right back, guys. I just got to make sure that we're streaming properly on LinkedIn and YouTube as well, okay? Righty, thank you, everyone.
to try to truly credit his influence in the world of ECMO, I think it is close to impossible, but I think it's fair to say that the majority of the ECMO care that's being done today, which is to the tunes of tens of thousands of patients a year, is very much a consequence of his passion, his compassion, his interest in the science, the technology, the physiology, but probably more so than that is his interest in the patient.
He is such a magnetic personality, amazingly positive, and really, no pessimism. So his positivity is one of the uh, character traits that I think has been so important in his ability to move something like this crazy technology forward and to bring people along. Um, Besides his brilliance, I mean, he's absolutely brilliant.
Dr. Bartlett was always passionate about education. He was passionate about teaching people the things that he was passionate about. And so it was very, very common for Dr. Bartlett to be called upon for advice. And for years and years, he always knows what to do. Even when the problem is unfixable, it's always reassuring to speak to him, to get great insight.
He was thoughtful with the early education of the ECMO specialists, the bedside nurses. When we did patient rounds again, he would include all these individuals, ask them for their opinions, their thoughts, their observations, their ideas. He would make everybody feel that they were an important part of the team and the patient's care. It reminded me that although complex medical care requires an understanding of anatomy and physiology and technology and numbers and can sometimes make you feel distant from the patient. He always made the patient front and center.
We're very proud of the fact that ECMO has developed around the world so that there are now hundreds of thousands of cases being done everywhere. Well, what's my legacy, I guess you'd say, or what's my contribution to medicine overall? People think of ECMO because it's a big, complicated technology that's working well, and that's been a major contribution. The thing I'm most proud of is all those medical students and residents and research fellows that have worked with me and our team in the lab, literally thousands of them over the years, who are now out in the world being good doctors and good scientists and so on. So that's my major contribution to medicine overall.
Well, thank you, everyone. And we'll get started in about 3 minutes, okay? All right, good morning, everyone. My name is Javier Amador Castañeda. I am a respiratory care practitioner at Columbia University Irving Medical Center in New York City. I do not have any disclosures to report. I am here today along with my colleague, Dr. Bruce Mina. Dr. Mina, if you can please introduce yourself and any disclosures you may have.
Good afternoon, everybody. I'm Bush Ramina. I'm the Chief of Pulmonary Critical Care at Northern Westchester Hospital, New York. It's a pleasure to be here and having great speakers for the talk about
Thank you so much, Dr. Mina. And on behalf of the Society of Critical Care Medicine's ARDS Innovation KEG, I want to welcome you to today's webinar on ventilator management in ECMO for ARDS, navigating the balance between lung rest and lung protection. And before we begin, we would like to dedicate this session to the memory of Dr. Robert H. Bartlett, the father of ECMO, who passed away on October 20 at the age of 86. Dr. Bartlett's lifelong commitment to advancing extracorporeal support transformed global critical care. From his early work on the artificial lung to more than 5 decades of continuous NIH funding, to the founding of ELSO and its registry documenting over 100,000 lives saved, his legacy continues to shape every clinician who touches ECMO today. He was a pioneer, an educator, and a mentor whose work will remain foundational for generations to come. Today's session brings together two international leaders, Dr. Matthew Schmidt and Dr. Ibrahim Fawzi Hassan, who will guide us through the evolving science of ventilator management during ECMO, from the debate over lung rest versus lung protection to practical strategies for individualized ventilation and weaning. Thank you for joining us. It is now my honor to welcome Dr. Schmidt to begin today's presentation. Professor Matthew Schmidt is a professor of critical care at Sorbonne University in Paris and senior intensivist in the medical intensive care unit of Pitié, I'm going to mess this up, Salpêtrière Hospital in Paris. His research interest spans the fields of mechanical circulatory assistance for severe acute respiratory distress syndrome and cardiogenic shock, including ECMO. Dr. Schmidt, the floor is yours.
Thank you very much. So, hi everyone. My pleasure to be here. Can you see my slide?
Yes, we can see your slides.
All right. So, what we have to discuss together during this roughly 20 minutes is the big question about how to ventilate a patient on ECMO and to try to convince you during these 20 minutes that we have at least enough evidence to support ultra lung protective mechanical ventilation on ECMO. So here are my disclosures, some lectures fees for some companies and some research grants obtained from the French Ministry of Health, mainly to fund RCTs. So we know that if you apply protective mechanical ventilation, if you religiously apply protective mechanical ventilation in patients with severe ARDS, we know that for a couple of patients, will exhibit what is called tidal hyperinflation. In fact, it is represented on these CT slides by all these red spots, which mean that you are actually over-distending the safe zone of the lung despite religiously apply the guidelines about protective mechanical ventilation. And if you look at the alveolar stage in the alveoli by doing a bronchoalveolar lavage, by dosing a couple of cytokines, inflammatory mediators, you will see that those patients who exhibit this tidal hyperinflation had a huge inflammation compared to patients who did not have this tidal hyperinflation. So the underlying message of that is quite straightforward and quite simple. In fact, the smaller the baby lung, meaning the sickest your patient, the greater is the potential for unsafe mechanical ventilation. So we have to find a way to treat our baby lung gently and to find a way to ventilate appropriately our patient on VV ECMO, which are by the definition the sickest one. And the principle of VV ECMO is obviously to replace the pulmonary function, to normalize your blood gases. But why it works? It works because during that time, we will stop aggressing the lung, we will allow the lung to rest, and by this way, we will get some additional time, days, weeks, or even months for the sickest, to allow healing of the lung. So the challenge on VV ECMO will be to markedly reduce the mechanical power, and we will see together how to do it. So this is based on decades of research, which has shown that there are several physiologic mechanisms of ventilator-induced lung injury, several components, like the volume trauma, the barotrauma, the atelic trauma, the biotrauma, but also the myotrauma, which is the inactivity of the inspiratory muscle for a prolonged period. So our job as a clinician, when we are managing a patient on VV ECMO, will be to try to minimize this lung stress and strain by trying to integrate all this physiological research which has been done since a few decades. So our primary job will be to reduce the mechanical power. The mechanical power is expressed by this complex equation that no one knows by heart, but what is important to retain is that you have several components of this mechanical power. You have on one side the tidal volume, the flow, the driving pressure, and we have also the respiratory rate, which is participating a lot to the mechanical power. So we have to reduce these parameters. And this is what has been illustrated in this cohort when we simply follow 350 patients on VV, when we follow day by day how was the mechanical power in your patient. You see that before being on ECMO, the mechanical power is extremely high because you are struggling to maintain adequate blood gases with mechanical ventilation, and mechanical ventilation is not enough. So you start VV ECMO and then you start resting the lung by markedly decrease mechanical power. And when the patient is almost has benefit from VV ECMO, when the patient is almost ready to be decannulated, then you need to reload the lung. So the lung is now participating to gas exchanges, and you see that the mechanical power that you obtain after ECMO decannulation is much lower compared to initially. So how to decrease the mechanical power? What is the evidence? The evidence is coming first of all from this prospective randomized control trial, which is the extravent study done by in Germany, which suggests to reduce the tidal volume in this very simple RCT. They took 79 patients. Half of the population was ventilated in a classical way, so meaning 6 ml per kilogram ideal predicted body weight. The PEEP was set following ARDS net strategy. So this is a control group. And the interventional group, it was decided to arbitrarily reduce the tidal volume from 6 to 3 ml per kilogram, and to compensate the respiratory acidosis induced by this tidal volume reduction, they add a CO2 removal device. The primary outcome was ventilator-free days at day 28 and day 60. And as you see in the whole population, which is a mix between severe, moderate ARDS, you see that the primary outcome was not different between the two groups. But what is interesting is this secondary analysis when they focus on the most severe patient, meaning the subgroup with a PF ratio lower than 150, which is a target population on ECMO, I mean the sickest one. You see that when the PF ratio was lower than 150, so we can guess that in that situation, the baby lung was the smallest. You see that reducing the tidal volume from 6 to 3 was associated with significant more ventilator-free days at day 28 and day 60. However, if you markedly reduce your tidal volume, you may cause pulmonary derecruitment, and you have to play with the PEEP to try to minimize or to compensate this derecruitment induced by the tidal volume reduction. And this is a key role of the PEEP. So setting PEEP on ECMO is not so obvious because you need to adapt it to your patient, and it's going to be probably discussed in the talk of Ibrahim. But what has been suggested so far, even if it's observational study with a weak level of evidence, it has been suggested that having a high people level on ECMO was a protective factor against ICU mortality and the time to ICU death. It was an independent protective factor against mortality. So if on one side, I told you that we're going to decrease the tidal volume, so it means that we're going to decrease the plateau pressure. And on the other side, we may need to increase your PEEP level. So at the end, what I'm doing, I'm reducing the driving pressure. And on ECMO, you can safely reduce the driving pressure. And this is one of the major goals of EV ECMO, is to reduce the driving pressure. So we know from this landmark study, which show the relationship between the relative risk of death in the hospital based on the driving pressure. You see that roughly the relative risk of death is below 1 when the driving pressure is below 15. So on ECMO, because most gastric changes are insured by the device, we can safely reduce the driving pressure. The target on ECMO should probably be below 15 centimeters of water. This is what has been suggested by this study based on the LSO registry, which suggests that whatever the matching you do, they found that patients on ECMO were ventilated with a driving pressure lower than 15 had a lower mortality compared to those who were ventilated with a driving pressure over 15 centimeters of water. So we know that we have to reduce the driving pressure. To what extent we should reduce it, this is still a big question mark. And I told you that the main objective is to reduce the mechanical power, but in the mechanical power, we have the tidal volume, the driving pressure, and the flow. But we should also not forget that the reduction of the mechanical power is also mainly driven by the reduction of the respiratory rate. This is shown in this editorial when they show that in the earlier trial, in the lifeguards cohort, you see that most of the mechanical power reduction was ensured by the reduction of the respiratory rate. And again, what is the evidence to support that? Again, back to physiology with some very simple physiological study, but very interesting one to progress in our practices. You see this study when they took one group, classically ventilated with a tidal volume of over 345. The respiratory rate was set at 30 breaths per minute. And the interventional group, they set exactly the same tidal volume, but they reduced the respiratory rate from 30 to 14. And to be sure that the respiratory rate will be the only one difference between the two groups, they had a CO2 removal, and by this way, a CO2 removal device, and by this way, they were able to maintain exactly the same PCO2, exactly the same pH, and the same PaO2 PF ratio. So the only difference between the interventional group and the control group is the respiratory rate, which has been decreased from 30 to 14. And they show again that with this very simple intervention, they were able to markedly reduce the inflammation, the biotrauma in the plasma. They show that most of the cytokines were reduced, markedly reduced by this reduction in the plasma, but also in the bronchoalveolar lavage, so at the stage of the alveoli. Just a very simple intervention like reducing the respiratory rate led to a lower local inflammation. At some point, we have to promote spontaneous breathing because we have also to fight against myotrauma, which is the rapid atrophy of the inspiratory muscle due to inactivity. And we know that it came very quickly. After 72 hours of total inactivity, you may see histological lesions of diaphragmatic dysfunction. So we have to fight against this and to try to avoid ventilator-induced diaphragmatic dysfunction. For that, it means that we have to promote spontaneous breathing. But on the other hand, I told you initially that we have to control the driving pressure, the tidal volume, the respiratory rate. So one way to combine those two objectives maybe could be to use a mode which is BPAP, APRV, which is used quite frequently on ECMO because it allows you on one way to control the plateau pressure and the driving pressure and the PEEP. And on the other way, it let your patient a certain degree of freedom to do some spontaneous breathing. But what is interesting with this mode is that the spontaneous breathing is not synchronized with pressure cycle. So it means that every time the patient will trigger, it will not receive an additional cycle, because what you don't want to push the balance too far and to have deleterious effect of spontaneous breathing with huge transpulmonary pressure swings. So this is why this mode could be an option. It's not mandatory, but it could be an option to combine these two techniques. All of this, what is called ultra-lung protective mechanical ventilation, have been investigated in the two landmarks RCTs, when the intervention was to set ECMO in the intervention group, but was also to pay attention to the ventilator and to markedly reduce mechanical ventilator, to markedly reduce the respiratory rate, the tidal volume, the plateau pressure, the driving pressure, and the FiO2. So again, if you start with ECMO, you have to play with the ventilator to promote ultra-lung protective ventilation. So this is something also which is proposed by the recent guidelines done by ELSO, suggesting that we should target ultra-lung protective ventilation. However, there are many uncertainty in that field, and clearly research is ongoing, but it takes time to make good research in that field. One big question mark is should we prone our patient on ECMO, because proning is a very efficient way to enhance ventilator-induced lung injury prevention. So could we or should we combine ECMO plus prone positioning, because we know that technically it's feasible to prone ECMO patient, and is it interesting for our patient on ECMO in order to enhance ventilator-induced lung injury prevention and maybe to better protect the lungs? For now, the evidence, even if we got many observational studies suggesting that it could be interesting, the only one RCT in the field published in the JAMA in 2023 did not show any benefit of a routing prone positioning on ECMO with exactly the same rate of successful weaning in both groups. So for now, we can't advise to do it in routine, even if the rationale seems strong. But again, we need more data, especially in non-COVID patients, because this prone ECMO trial was mainly done in COVID patients. Another big question mark is, could we reduce mechanical ventilation further? Should we? Could we? I think we can say already that it's feasible. It's technically feasible. I can't even stop my mechanical ventilation on VV ECMO, because to remove CO2 with this device, it's extremely easy. This is just an experience when they decrease step by step the tidal volume for 8 milliliter to even 0. You see that at the end, the ECMO device is able to compensate the high PCO2 and to maintain the PCO2 at an acceptable range. So is it interesting to go to something which is close to an apneic ventilation? We have few data suggesting that it may be promising on ECMO. We have this data based in an animal study when they investigate several strategies of ventilation, and one was a near apneic ventilation when they reduce the respiratory rate at 5 and the driving pressure was at 10. They show that with this strategy compared to other, it was a strategy where the mechanical power was the lowest and when the driving pressure was also markedly decreased. And when they sacrifice the animal and they look at the histological lesions of lung damage, they show that the condition when the histological damage was the less predominant was the near apneic ventilation. What about in human? We have this very interesting study from the team from Toronto, when they again investigate several mechanical ventilation strategy on ECMO, and you see that you have this strategy B, which is a CPAP. It means that you apply only PEEP. You are not ventilating anymore your patient. And they show, even if it's not a strong outcome, but they show something which seems promising. They show that the condition when the inflammation was the lowest was the condition, the CPAP condition, suggesting again that using CPAP maybe for a short period of time when the inflammation is extremely intense at the beginning of the VV ECMO run could be an optimal ventilatory strategy to minimize again ventilator-induced lung injury. So this is why there are 3 ongoing RCTs which are trying to answer this crucial question. One CT in UK, one RCT in Canada, and the other one in France, the Calm Down trial. The 3 trials have exactly the same aim to try to compare classical ultra-lung protective ventilation versus apneic or near-apneic ventilation for a short period of time, from 48 hours to 72 hours, when the inflammation is extremely high, so meaning at the beginning of the ECMO run. So using VV ECMO should be always accompanied to a markedly reduction of the mechanical power, because this is why it works, is because you apply a ultra-lung protective mechanical ventilation, you are resting the lung. We have enough evidence now to suggest that the tidal volume should be reduced, until which point this is still a question mark, but at least reduced much lower than 6 ml per kilogram. So let's say lower than 4. The driving pressure should be lower than 15 centimeter water. We have to decrease the plateau pressure lower than 25 centimeter water. The respiratory rate, which is frequently neglected, should be reduced as well to 10, 15, or even 0. I don't have this answer, with the idea to further reduce ventilator-induced lung injury. And we have to play with the PEEP to try to prevent a lung derecruitment. We have still many questions in the field. Studies are needed and studies are ongoing about the PEEP role, about any benefit of prompt positioning to further protect the lung. Promoting spontaneous breathing, it's easy to say. In practice, it could be much more complex. So we have to find a way to better control the central drive to promote spontaneous breathing without having the deleterious effect of spontaneous breathing. Thank you for listening.
All right. Thank you so much, Professor Smith, for such an informative presentation. There are quite a few questions, but we'll leave that at the end for the last 15 minutes for a Q&A section. At this moment, I would like to introduce Dr. Ibrahim Fawzi, who graduated from National Medical University with honors and completed his residency and fellowship at New York Presbyterian Hospital, Weill Cornell Medical College in New York. Dr. Fawzi joined HMC in 2011 and is currently the Director of the Corporate Critical Care Center, Director of the MICU, Deputy Medical Director of the Hamad Medical Corporation Ambulance Service, and the Clinical Lead for the Severe Respiratory Failure ECMO Program. Dr. Fawzi has won several awards during his career, including the Alpha Omega Alpha Award from Cornell and the Young Clinicians of the Year Award from Cleveland Clinic, Middle East. In his current role, Dr. Fawzi is leading several important projects for HMC, including standardizing critical care services and the ECMO programs. At this moment, I would like to introduce Dr. Fawzi. Dr. Fawzi, the floor is yours.
Thank you very much for the great introduction, scientific and organizing committee. A privilege to be part of this great team. And also, it's great to hear to my friend Matthew, who's actually currently in Qatar, supporting with the ECMO training. So my talk is, I'm very excited to be here, and this is our actual logo, is ECMO Simulation Team of Doha. So I'm very happy to be here with you today. I have no conflict of interest to share. And the talk that I'm focusing in a few things, really, which is, I think we need to understand the different phases of lung involvement in ARDS before we commence in the weaning. Matthew clearly talked about the acute inflammation and how lung rest is important. But as important is good to understand the different phases, and I'm going to talk you through that. Also, we need to understand what are the challenges when the ECMO started to be prolonged, and how to assist lung recovery on VV ECMO. And finally, how should we wean? Should we wean ECMO first, or should we wean mechanical ventilation first? This is a classic ARDS with a very non-recruitable lung, severe acidemia. You put them on ECMO, they do very, very well in the beginning. Hypoxemia get better. Most of the studies was done in the acute phase, really, in the inflammation. And this is all the data that was shared by Matthew, and more to come in the randomized trial. But if you look to the lung support and the course of mechanical ventilation and the lung recovery over the period of time, you will see in one axis is the amount of support and the mechanical ventilation. So lung function in the beginning is very, very limited. There is no much lung function, and mechanical ventilation support is usually 100%. Before they go in ECMO, once they give you ECMO support to start to kick in, native lung function is still very poor, and you are depending on the ECMO support. And this is the acute phase where you do your ultra protective lung ventilation, you optimize the lung function, and you try to treat the cause. By time lungs start to recover, so the ECMO support to start to come down, and then the native lung function slowly start to recover until you go to the weaning. And this is the sweet spot that you really we need to be able to identify and to try to early identify that part and start to support the organ. So if you look to the two courses, early course with a severely inflamed lung, this is usually can be for a few days, but also can extend to weeks, depending on the pathology and the cause of the lung inflammation. And then you have the late course of the lung recovery. It would have been nice if that's the only two period in the lung inflammation. Unfortunately, in between them, there is a transitional period. And this transitional period can be tricky. Is not most of the study you look for 30 days, 60 days mortality. Many ECMO patient will have 3 months on ECMO, and even longer. In deterioration, patient can get worse. A lot of fluctuation in the radiological finding, and it's sometimes difficult to recognize the moment when the lung has meaningful recovery and when our strategy must be bioed. So what are the challenges that we face during this period? And during this period is we have a severe muscle weakness, most of the paralytics, maybe has steroids, very high catabolic state, and they lose a lot of their muscle. Their lung is either minimum or no tidal ventilation for several weeks. And again, because of the long rest ventilation, which is important, but they also will suffer from severe diaphragmatic dysfunction. And this is a key for all the problem that we try to avoid. Tracheostomy is almost universal, and many of these patients will have delirium that make things a bit difficult. So when recovery begins, we face two major questions. One of them is, when should we initiate use the lung concept? So rest the lung concept is done. Now we need to use the lung concept and use the muscle, diaphragmatic muscle, more frequently. And it's a balancing really two competing risks. One is vent-induced lung injury, and the second is diaphragmatic dysfunction and deconditioning. And this balance really requires multiple trials back and forth. There is no magic day where you're going to switch. I think based on the phenotypic assessment only is not enough, and I think we need to be able to get some biomarker that can help us to identify that. But from phenotypic data, we look for early sign of lung recovery. The first one is usually exhale tidal volume that will start to improve, especially if using pressure controlled ventilation. If you use volume controlled ventilation, the overall pressure to deliver the same volume will be lower. Dead space fraction will be lower. So end-tidal CO2 is a very important parameter to follow. When this number start to improve and the ratio of the dead space start to decrease, we know the ventilation of the lung is getting better. Oxygenation and CO2 clearance also get better. So the amount of ECMO blood flow that require to maintain saturation will come down. Fraction of the liver O2 and the sweep gas also will come down. And the CO2 clearance will be manifested by either patient will become more alkalemic, and then you have to decrease the sweep gas flow. So these are all marker of the lung started to go in the recovery phase. And sometime if you do intermittent radiological imaging, whether X-ray or CT scan, you will see a bit of more aeration in the lung. And once these signs start to come up, we always need to think, okay, maybe it's a time is enough for the time rest, ultra protective ventilation. Can we recruit this lung more? Is the inflammation is controlled? Should we try to avoid diaphragmatic muscle dysfunction? And you know what? Actually train the diaphragmatic muscle, get the muscle strength up. There is plenty of studies on vent-induced diaphragmatic dysfunction. ECMO and severe respiratory failure is no different. So what would be the mode of ventilation at this stage? Would APRV is the way to go, where NAVA is another way to go, pressure support or proportional assist ventilation, IntelliVent, and more mode of ventilation that go in this recovery phase take place. Obviously, one concept to remember, and Matthew alluded to, is recruitment. Probably recruitment at this time is actually more important than to do it on the acute inflammatory phase. So to maintain recruitment and identify the optimum PEEP at this stage probably would be good. Although we don't have any data on which mode to use, it will be pretty much depending on the center experience, because unfortunately, if we have a little or limited study on ventilation on ECMO in acute phase, in the transition phase and in the weaning, the data is very, very limited. No much studies in this field. So question remain open really, and there is no, as I said, scientific evidence demonstrating superiority of any models on this of this mode of ventilation, and it's pretty much dependent on center experience, capability of the vent that's available, and obviously patient response. The key component really to, I know we don't talk about mechanical ventilation, but I think it's not just that. Is more important is to have a prevention of infection, because another episode of septic shock of this recovering lung will just put the patient completely down. So preventing of nosocomial infection with a very strict infection control is essential. The second, which is the biggest headache really, is the delirium and the sedation management. Sedation weaning, comprehensive management of the delirium of crucial importance. So the patient can participate in physiotherapy and inspiratory muscle stimulation, whether inspiratory or expiratory muscle improvement, as well as swallowing muscle evaluation. So it's a period of really good rehabilitation. And without say adequate internal nutrition and progressive physiotherapy, I think these are the really recipe for success. I'm not sure of type of mechanical ventilation.
Hello, everyone. Just please bear
Apology,
with us. We're having some technical difficulties, but Dr. Fauci, if you're able to reconnect and share your slides.
absolutely. Did I stop for a long time, or it's can you see my slide?
Yes, we can see it now.
Apology. Did
Yeah.
I miss a lot of how long I've been out?
No, you were only off for like maybe 20, 30 seconds.
Okay,
The only
very good, excellent.
the only thing we're getting from our viewers is that your camera is sort of obstructing some of the slides, so they're not able to see them all. I don't know if
Oh,
you're, yeah,
apologies.
that would be better. Yes.
Oh,
It's okay
apologies for that.
if we don't say, yep. All right. Thank you so much. You can resume, Dr. Fauci.
Apologies. So, as I said, the essential component of accelerated recovery is a strict infectious control to prevent new infection, as this is recovering lung will not tolerate the massive increase in minute ventilation. Aggressive management of sedation and weaning of sedation and delirium management, and obviously adequate nutrition, progressive physiotherapy, and a very good training of the inspiratory and expiratory muscle, and a swallowing rehabilitation. And again, the question is, what should we do first? Should we take the ECMO? Wean the ECMO, which is, I think, it's a standard practice really for a short ECMO run. Viral pneumonia for 2 weeks, 3 weeks, they get better. You wean the ECMO, and then you can wean mechanical ventilation and extubate easily, or decannulate tracheostomy. But patient who has a prolonged ECMO run, you're talking about months, few months, they get a chronic debilitating condition. And taking the ECMO out might be of a risk because their respiratory system will not tolerate any new head. And maybe it's a good to keep the to ECMO to facilitate physical rehabilitation. And I give you an example of a young lady who's previously healthy, really, with devastating bacterial pneumonia, 4 months in ECMO. She was actually colonized with multi-drug resistant, profound muscle loss, delirium, severe weakness. She was declined for transplant, minimal physiological reserve. And if you look to her CT, she has barely any lung left. And many of our team members were, okay, this patient, probably we should not do any escalation of care and stop there, because that's 4 months of ECMO therapy. And if you look to her CT in a few months later, she's still very weak, but her lung did show some sign of improvement over a period of time, and her exhale volume start to improve, and her lung continues. Lung is an incredible organ with a significant ability to regenerate, which was good. But in 6 months, she did tolerated ECMO weaning. So they could actually wean the ECMO, but she was in a moderate dose of mechanical ventilation. And question again came, should we wean mechanical ventilation first, or should we wean the ECMO first? So option one is always comes in these cases. Well, ECMO can provide a safety net during physiotherapy and respiratory retraining, because these muscles need a lot of exercise, whether you're skeletal muscle, whether you're diaphragmatic muscle, and this is adds significant complexity to CO2 production, and maybe the native lung cannot cope with that, except if you give them a high dose of mechanical ventilation. So it gives you this luxury that you can actually, with a sweep gas, you can control all of that. But the risk is obviously prolonged ECMO complication is bleeding, is thrombosis, infection. And this particular patient, she had a spontaneous rectus sheath hematoma with hemorrhagic shock that required massive transfusion. Now, if you wean the ECMO first, you can avoid all this complication. However, your lung might not tolerate any sudden increase in ventilatory demands. If patient became septic, would you recannulate? So after all this hard work over several months, that's something we will give up. So it's I don't think anyone knows the right answer. For us, we would actually shrink back her swallowing mechanism back, and then she was decannulated from ECMO. She did very well. It doesn't mean that what we've done is the right thing to do. I don't think anyone really know yet, but this is the area of research as well, especially when a difficult to wean patient. And again, it go back to the strict infection control standard precaution, hand hygiene, adequate nutrition, a very good rehabilitation team and mobility, physiotherapy on ECMO, and delirium. Get them out in the sun, and really to try to get the delirium better, and then hopefully the overall they get respiratory muscle back and can be weaned. So key principle and takeaway message is number one. I think it's really important to define that there is not just the acute inflammation and the weaning phase. There is a significant transition period that can vary from a patient to a patient, and can fluctuate back and forth. And I don't think we know for sure when to switch from the rest the lung concept to use the lung and prevent diaphragmatic dysfunction concept. Is something that's still early to define. Timing, the shift really matter, and we depend on a physiological data with a phenotypic data, but I think we need more research and genotypic and omic to guide us on a recovering lung, to be able to evaluate that in a better way. There is no superior weaning mode, whether it's a NAVA, whether it's a PAV, whether it's a APRV. It's all depend on the center experience, but I think the long recruitment and PEEP optimization is something that need to be evaluated a bit more. Weaning order must be individualized, whether you take the ECMO out first or the mechanical ventilation. I think it's all depend on the lung reserve. If the lung reserve is good, and especially the performance status is good, then taking off ECMO quickly should not be a problem. But if the patient is severely debilitated, lost a lot of muscle, in severe malnourishment state, I think it have to be carefully considered to continue ECMO to facilitate physiotherapy and get the patient in a better shape before we take the ECMO off. And prolonged ECMO require really a holistic strategy. Muscle rehabilitation, delirium management, nutrition, infection control, and team coordination are often more important than what type of ventilatory mode is being utilized. So in conclusion, weaning from mechanical ventilation and ECMO in severe respiratory failure is not a protocol. It's a dynamic, individualized process. Until we have solid scientific evidence, clinical judgment and MDT experience remain really the cornerstone. With that, I end my talk. Thank you all for listening. Happy for any questions.
Hi, everybody. It's a great webinar, and I like the harmony between the two speakers, and get in touch about the other aspect, how we deal with ARDS, with nutrition, delirium. I like the picture on the wheelchair with the ECMO machine up in the green grass. I mean, we forget that the effect of all sedation, paralytics, and being sick, how that can affect the mental status. We have two questions. One is from Dr. Joan Gallagher. I think for you, Dr. Schmidt, do you see a role of EIT in the management of these patients in the setting of tidal volume and a PEEP in this patient moving forward?
Yes, EIT, it's a possibility. It's an additional tool that you can use at the bedside, especially early on, like Ibrahim said, during this very inflamed period of time, which could be several days or even weeks. In that period, it's very important to set well the PEEP, because on one hand, if you put a too low PEEP, it's going to be a day recruitment, and the other end, too high PEEP, it may lead to an over dysfunction of the safe zone. So EIT could play a role in that case. This is something that we have investigated a lot, but you can use EIT, but you can use also esophageal pressure to try to guide you at the bedside to put the right PEEP for the right patient at the right time.
Javier, do you have any question on Lincoln?
I do not have any questions at the moment from LinkedIn or our YouTube live. But I do
Yeah.
have a question, Dr. Schmidt. For those academic institutions, actually those that are not academic institutions and do not have the privilege of having EIT and esophageal manometry, what method do you suggest or recommend for optimizing PEEP? Any way of optimizing PEEP via driving pressures, recruitment to inflation ratio? What method do you think is the best for those that do not have EIT and esophageal manometry?
Yeah, it's a very good point. I think before going to EIT or transpulmonary pressure or esophageal pressure, you can use simple tools. And we have demonstrated last year that, first of all, doing recruitment to inflation ratio works, even if you have a very low tidal volume. So typically a patient on VV ECMO. So if your recruitment to inflation ratio is below 0.35, it means that the PEEP level, the optimal PEEP level should be 8 to 10. It could be enough. So you can stop at that point. However, if it's over 0.35, it means that you have a potential recruiter in front of you. And then this is maybe the situation when EIT or transpulmonary pressure could be interesting to really find the best PEEP which fits with your patient. One last point, and I think there is another thing that we have to do when we are setting PEEP is to look for airway occlusion pressure. This is something which is extremely simple to do at the bedside. Having an airway occlusion pressure, it seems to be quite frequent on ECMO and may represent 20 to 25% of that population. So with this very simple intervention, which takes you 2 minutes, with any ventilator, you can do it. At least you know that if you find an airway occlusion pressure, you know that the optimal PEEP of your patient will be above that airway occlusion pressure. So having a first step with airway occlusion pressure, recruitment to inflation ratio, you already have lots of information that may prevent you using more complex tools like EIT or esophageal pressure.
There's another question, and either one of you can answer it in the chat from Dr. Masha Filter. What is the sufficient PEEP on VV ECMO?
What's the question?
What is
What
the
is
sufficient PEEP on VV ECMO?
How to set the PEEP on VV ECMO?
Yeah.
What is the optimal PEEP?
So that's a very good question, and again, I wish we know the answer. Most of the study of PEEP and ARDS was not positive, and because I think we're still learning about the PEEP, we're still learning what's the optimum PEEP, and I like the question that you asked for. What do you do if you are not in a you don't have visual manometry or a way to measure transpulmonary pressure? Well, very few centers really have transpulmonary pressure as a way of doing that. And, there is many other way at the bedside you can do. Pressure volume loop is one, but also PEEP titration with calculating the compliance to get the optimum PEEP. You can measure end-tidal CO2 as a marker of pulmonary blood flow. And this is really done in many centers, titrating the PEEP to the best end-tidal CO2. Which will tell you that is the best PEEP that give you the best pulmonary blood flow. If you have volumetric CO2 will be better, but also ultrasound can be incorporated in the equation. Now, how to set the PEEP in ARDS? In our center, we have to define the phenotype. So everyone with ARDS in VV ECMO, they get a recruitment CT scan. So we assess the lung recruitment with a low PEEP and high PEEP. If the lung is recruitable, not recruitable, there is no point of really setting much of the PEEP. I think these are the group that you need to give them ultra protective ventilation without any high PEEP because, the lung is completely non-recruitable. But you will be surprised. There is a significant fraction of these patients, these still recruitable. And I think these are the group that you probably need to set their optimum PEEP because you are de-recruiting the lung. I know the concept is we have to rest the lung. This is the concept. We have to rest the lung, but we don't want to de-recruit the lung at the same time. You don't need to do tidal ventilation, but you need to set the PEEP up. So it's very important to identify upfront which of this ARDS patient is recruitable. If they are recruitable, we should avoid the recruitment and find the optimum peak. In our center, we combine two strategies. We don't do that transpulmonary pressure. We do a PV loop with a hysteresis curve and end-tidal volumetric CO2. So one methodology for PEEP optimization is not enough for these patients. These are the patients that you need to combine your strategy, whether it's a radiological imaging, whether it's a PV loop, whether it's a more pulmonary blood flow assessment to get your optimum PEEP. And then you set the PEEP and just avoid any ventilation, injurious ventilation. I don't think we have enough data on that yet, but you know, have no data will not prevent us from doing the physiology and doing what we think is right. And that's what we do in our center. Again, it's up for more discussion and a study that can help us a bit more. But it's really important to identify which patient is recruitable. So this is the people that you need to target. If they are not recruitable, don't waste your time in the people.
I have a question about proning and ECMO from the slides you showed that proning did not really improve mortality. If this is related to patient selection in these trials, or as we know that the window for proning in the early ARDS, the earlier it is implemented, the better the prognosis. So is it just there's a sick population versus a timing of proning in regard to the onset of ARDS, and that's why it didn't work in ECMO.
In the PRONECMO trial, one specificity of that trial, even if it was not done on purpose, but it mainly include COVID-19 patient. And clearly COVID-19 patient, especially on ECMO, had an extremely long run, high mortality, very long time to recover, and so on. So I think we can conclude it's possible to conclude that for this subpopulation, routine prone positioning didn't work. But I don't think we should say that it doesn't work for anyone. And so this is the first possible explanation why so many observational studies were in favor of proning on ECMO, and the result of this trial were quite disappointing. And the second thing is that as you said, those patients also were already ventilated with ultra-long protective ventilation. So it means that those patients were already, the lung of these patients were already protected with this strategy of resting the lung. So maybe in that case, adding prone positioning on top of that in order to further improve, to further enhance ventilator-induced lung injury prevention may be not so useful. But again, this is something that we have to demonstrate with classical ARDS when the recovery is much quicker. So it means that an early intervention may potentially an impact on the late recovery.
There's no more question in the chat.
Yeah, I do not have any questions on LinkedIn and YouTube. If you guys have any questions, we got about 5-6 more minutes. Please feel free to input your question at this moment. So, Dr. Schmidt, just one quick question. At my institution, usually when we cannulate someone and we put a patient on VV ECMO, our settings that we go to is pressure control with a rate of 10, inspiratory pressure of 10, initially 100% FiO2 and a PEEP of 10. However, there is those instances where we get those patients with a very high BMI. And a lot of the times we follow our protocol and we tend to leave patients sometimes on a PEEP of 10. And sometimes I feel like these patients would probably benefit a little bit more by using APRV. So my question to you is, when you get someone at your institution, what are the initial settings that you go to? And do you normally go to those pressure control settings that we all use? Or do you say, I think I'm going to use APRV on this patient because it may be more beneficial?
So in my institution, we use APRV for everyone since day one. Obviously, if the patient is deeply sedated at day one, it's a pressure control mode. It's the same because you have no spontaneous breathing, so it's almost the same. But our initial setting will be to target the driving pressure. So we target the driving pressure at 12, 14, but clearly below 15. And you will base your upper pressure based on the PEEP level. So we can say that a classical minimum PEEP level on ECMO is 10. You have very, very few patients with a PEEP lower than 10 because you have to compensate the potential derecruitment induced by the tidal volume reduction. If your patient is obese, like we have seen during COVID-19, PEEP at 10 is probably the minimum. But some patients may clearly benefit from much higher PEEP. 14, 15. And I am very aligned with Ibrahim. I think having a CT could be also a useful tool to help you to try to find the phenotype of your patient. If you have really a posterior consolidation with the ventral zone still aerated, it may tell you that, first of all, your patient may be a responder to prone positioning. And second things, it may help you also to increase your PEEP level. So we set the PEEP level, and then we add 12 centimeter of driving pressure on top of that. And normally, classically, the high pressure is around 24, 25 maximum. And we try as much as possible to have the lowest FiO2, and we maintain 100% on the FMO2 on the membrane, because the idea is to prevent the potential toxicity of inhaled oxygen. So that's why it's actually recommended to try to minimize the FiO2 while playing with the FMO2 on the membrane.
There's another question was Dr. Masha Fieldner. During weaning from VV ECMO, what is the best mode to start the weaning? And with a weaning, what is the weaning protocol?
I think it's a $1 million question. I'm not sure if anyone knows what's the best. And as I mentioned, it really doesn't depend on the mode of the ventilation mode that you use, but more about getting everything else and whatever you're familiar with. If you're happy with NAVA, then go with NAVA. If you have with PAV, you go with PAV. If you do just pressure support ventilation, then that should be okay. I don't think anyone knows what's the best. The best is whatever you are familiar with for now, because we don't have much data to tell us which one is the best to do in a weaning, and whether extubation is the right way to go or a tracheostomy and an elaboration is the best way to go is not clear.
Okay.
Thank you, Dr. Fauci. And just in the interest of everyone's time, thank you, Dr. Schmidt and Dr. Fauci, for your outstanding contributions. And thank you to our global audience for your engagement throughout today's session. As we continue to refine ventilator management in ECMO-supported ARDS, today's insights remind us of the importance of balancing physiology, evidence, and patient-centered care. It also reminds us of the remarkable foundation laid by Dr. Robert Bartlett, to whom we dedicate this session. His vision continues to guide the work we do. And just remember that a recording will be made available through SECM. And on behalf of the ARDS Innovation KEG, thank you for being part of this international community. And we look forward to seeing you at our next session. So everyone have a great day, and thank you for joining us. Thank you for all the panel for being here with us. And we hope to have you here in the near future.